You're listening to the Blood Bank Guy Essentials Podcast, episode 020.
Our current strategy can only apply to transfusion transmissible agents that we know about. What that implies, or what that means though, Joe, is that essentially we accept the fact that some patients will be harmed before we figure out what to do. We're in an era where, to me, that's no longer acceptable.
Hi, everyone. Welcome to episode 20. That's 020 of the Blood Bank Guy Essentials Podcast. I really can't believe I'm saying that. It has gone so fast. And honestly, the biggest thing that I can say to those of you that are listening is simply thank you. Thank you so much. Thank you for listening. Thank you for your reviews on iTunes. Thank you for the nice things that you've said on Facebook. And just really, I can't tell you how much I appreciate it. Through doing these 20 episodes, I've connected with so many of you in so many different ways. So I'm just grateful. I'm just thankful that you're taking your valuable time to sit and listen to these podcasts. Today's episode is one that I am really excited to share with you. It is an episode that I've been trying to arrange for some time. It's an interview with Dr. Jeff McCullough from the University of Minnesota. And Dr. McCullough is literally a giant in our field. Okay, not literally. I guess he's not super tall, but he is a giant in the field of blood banking and transfusion medicine. And he and I are talking today about pathogen inactivation, or as some people call it, pathogen reduction. It's an incredibly timely and important topic, and he has a lot of great and very interesting things to say. And I can't wait for you to hear it. So I will stop talking now and give you my interview with Dr. Jeff McCullough. All right, everyone, as promised, I am really excited to introduce you to today's guest, Dr. Jeff McCullough from the University of Minnesota. Jeff, thank you and welcome to the podcast.
It's a pleasure to be here, Joe.
Really, really appreciate you being here. Everyone, I can't tell you how excited I am to have Dr. McCullough here. He and I have struggled to figure out how to make this work. It's a long story. Ask either Jeff or I about it sometime, but we've managed to connect, Jeff, and I'm very excited. So let me tell everyone a little bit about you. For those of you that have been living in a cave for the last number of years and are not aware of Dr. Jeff McCullough, Dr. McCullough is the recently retired Professor Emeritus of the Department of Pathology and Laboratory Medicine at the University of Minnesota. Congratulations on the retirement, Jeff. It's awesome.
Well, thank you, except I'm as busy as I've ever been, Joe, because while I've left the university, I'm not retiring. I'm continuing to work on a lot of different clinical trials.
And I would expect no less of you. And when everyone hears about all the stuff that you've done, I'm sure they would expect no less either. A couple of things in Dr. McCullough's extensive background. He went to medical school at Ohio State. He did his internship and residency at Vanderbilt and the University of Minnesota. And really, Dr. McCullough is an international leader in transfusion medicine research and practice, and has done great things in our industry. He is the co-founder, the founding president of the National Marrow Donor Program. He was the editor-in-chief of the journal Transfusion for 15 years. In addition, he was the president of the American Board of Pathology for a year, and has served as the principal investigator on numerous research products, including those in the area that we're speaking about today, which is pathogen inactivation. So, Jeff, I did want to give you the opportunity. I know that this is important to you. Before we start our topic, I know you've done a lot of work with pathogen inactivation, and you've done work with different companies. So if you wouldn't mind, would you go ahead and share with us what you'd like to share about any potential or perceived conflicts of interest?
Yes, Joe, thanks for the opportunity. I am a member of the Scientific Advisory Board of Fresenius Kabi, and have been for many years, although they're not involved in pathogen inactivation. Over the years, I have had research grants, both Cirrus and Terumo, but none of those are active now. And for at least the last 10 years, the important thing I want to say is I've had no personal consulting fees or no personal money from either of these companies. So I consider at this point I have no financial conflict of interest with any of the companies involved in pathogen inactivation.
Understand. Okay, that's awesome. The other thing that I want to make sure that everyone is aware of, again, before we get started, this is just something that I know is very important to you, Jeff, and I want to make sure that everyone is aware of the fact that Dr. McCullough is the author of, from what I consider one of the best transfusion medicine textbooks available. The textbook is simply called Transfusion Medicine. The current edition, and I say that with a bullet, but the current edition is the third edition, which is just a wonderful and really, really terrific and extensive review of transfusion medicine that you can find it really. You can find it on Amazon. You can find it multiple different places. I get no money from you buying this book from Jeff, by the way. So I tell you that I've recommended this book for a long time. And Jeff, I understand you've just finished the fourth edition, and it's becoming available right away, right?
The fourth edition, yes, the fourth edition will be at the ABB annual meeting next week. I got my first 2 copies yesterday.
Fantastic. Congratulations, man. Writing a book is a huge undertaking, and the fact that you've done 4 editions of this book is really wonderful. So congrats.
Thank you.
We are talking today about pathogen inactivation, and before we do that, Jeff, there is something that I always like to do with my guests, and we can do this very quickly, but I want to make sure that I give you the chance to just let everyone know. Many of the people listening to this podcast are people that are just trying to figure out what they're going to do with their lives and their career. And as I think you and I would both say, I think that blood banking is a wonderful thing for someone to do. But I'm curious, what was it back when you were at Ohio State or when you were at Vanderbilt or University of Minnesota in your training? What was it about blood banking that kind of grabbed you and made you think, wow, this is something I really want to do?
Well, Joe, it's an interesting saga to me, at least. I did not plan to do blood banking.
Really?
Toward the end of my residency, I wanted to do infectious disease. I was set to go to the CDC in what was then known as EIS, Epidemiology Intelligence Service. But the last year of my residency as chief resident, the guy who was running the blood bank got a huge NIH grant to which he had to devote full time. The department chairman called me into his office and said, well, Jeffrey, why don't you run the blood bank this year? And I said, I don't know anything about the blood bank. Well, the department chairman has a way of prevailing. And so he put me in charge of the blood bank, essentially the last year of my residency, and I've been there ever since.
Wow. So talk about serendipitous and lucky for the rest of us that you liked it, right? That's fantastic.
It's worked out pretty well.
It definitely has. That is for sure. All right. So Jeff, we're talking today about pathogen inactivation. But before we get to the details of that, I think it helps us to really set the stage. You have seen great changes in this industry in the time that you have been in blood banking. So why don't you start by talking just a little bit to us about and describing maybe how we have done with reducing the incidence of transfusion-transmitted infections and the approach that we've taken to do that historically.
Okay. Well, I think those of us in transfusion medicine and blood banking can be very proud of the marvelous success in decreasing transfusion-transmitted infections. When you look way back to the 1960s, for instance, about a third of the patients at the NIH who got a transfusion developed post-transfusion hepatitis. A third of the patients got hepatitis from blood transfusion. And then, of course, we're all painfully aware of the HIV epidemic.
Of course.
These days, there is very, very little. You can count on one hand, probably, the number of cases of transfusion-transmitted HIV, hepatitis B, and hepatitis C in the United States. So it's been a spectacular success. However, having said that, there are some limitations to this strategy. As I think everyone knows, there are several different approaches that have been used to be so successful. Laboratory testing of donors, the use of the medical history, the use of volunteer donors. Let me digress on that for just a second.
Sure.
There's a wonderful old graph that shows at the NIH Clinical Center the drastic decrease in post-transfusion hepatitis that occurred, and the single thing that accounted for that was a conversion from paid to volunteer donors.
Wow.
So we've done a variety of things to be so successful. Quality of the donors, the testing, the donor medical history,
Mm-hmm.
and these have led to the wonderful successes we've had.
Mm-hmm.
However, there are some fundamental approaches or limitations to this. And first of all, our current strategy can only apply to transfusion transmissible agents that we know about.
Ah.
It's a great example. We didn't know about it until it occurred. What that implies, or what that means, though, Joe, is that essentially we accept the fact that some patients will be harmed before we figure out what to do.
Mm.
We're in an era where, to me, that's no longer acceptable.
Right.
Also, our current strategies are only effective for certain kinds of situations. There are situations, for instance, for which we don't have a laboratory test, even though we're aware that transfusion transmissible diseases occur. A couple of examples are dengue, chikungunya, till recently Zika, malaria. We know about it, and there are tests to diagnose it, but there are no suitable screening tests for donors. So, where we are now is that we're aware of a number of different transfusion transmissible diseases for which there's no effective mitigation strategy. Mm-hmm. And while most of these diseases affect only a small number of patients, they're difficult to deal with in order to find an effective approach using the approaches that we've used over the last 30 years, that is testing donor history. Mm-hmm. So this sets the stage for a fundamentally different approach. Rather than donor medical history, laboratory screening, and so on, the approach that we're talking about here today, Joe, which is treat the blood product in order to inactivate any remaining infectious agents.
So more of a proactive approach rather than a reactive approach, as you were saying.
Yes.
Yeah. So before we get to that, Jeff, can you talk just a little bit about? I mean, I think Zika is a very hot topic. It's on everyone's mind, and I think most of my listeners will be aware of the fact that blood banks in the United States, in 11 different states, were recently required to implement Zika testing on all of our donors, and the rest of the United States is required to implement it within the next month or so. So I guess I'd like to get your take a little bit on this. So Zika, granted, it obviously is a significant disease, and we see lots of horrible stuff about it on the news. But I have a little bit of a hard time making the argument that Zika is a bigger public health thing than dengue or chikungunya. So why the big push? And I know this might be a question that it's impossible to answer, but why, in your opinion, why the big push for testing for something like Zika when there hasn't been a similar push for testing for dengue or chikungunya or babesia, for example?
Boy, you're starting right out with the hard ones, aren't you? I think it's because of the effect of the infection. Chikungunya is very painful. People have a lot of joint pains, but by and large, it doesn't have a permanent effect. Dengue is a temporary febrile illness. Of course, some people die of it, so it's severe. But with Zika, the effects on unborn children are enormous, and this has tremendous publicity. But it's not just the microcephaly. Apparently, there are other effects, some neurological and other long-term effects from these infections. So it really, in a lot of ways, is a more severe disease than dengue or chikungunya. Plus, the fact is, it has such visibility in the news. that,
Yes.
if you're the commissioner of the FDA, politically it's pretty hard to stand back and not do anything to improve the safety of the blood supply from Zika.
Right. Right. No, and I think that's an important thing for the audience to realize is that I agree fully with what you said, Jeff. It's there are multiple aspects to any decision like that, and the public visibility of it it raises the stakes somewhat, and not to say that Zika is it, and I didn't mean to say at the beginning that Zika is not important. Obviously, it is important, and obviously there's lots going on with it, and there are lots of challenges with it. It's just it goes to what I was driving at, and what you were alluding to before. How do you decide? How do you decide this is the test that the testing companies need to spend millions of dollars to develop versus this test, which maybe they won't. That's the challenge that we've dealt with in blood banking for a long time.
Yes, and let me add a couple of points there. First of all, I think we're lucky, and probably the public visibility of Zika is the reason that a couple of companies were willing to spend the money and the effort to develop a test.
Mm-hmm.
As you know, these days, this is a real problem. That often these companies are not willing to invest in developing these tests because they have no assurance that they'll be used.
Mm-hmm.
So that's one thing. And then the other thing about Zika, somewhat like dengue or chikungunya, as you know very well, Joe, something like 80% of the people who become infected with Zika don't know it.
Right.
And so this creates a unique risk for the safety of the blood supply.
Mm-hmm.
And it's why the original efforts were directed toward deferring people from blood donation who had been in Zika areas.
Right.
But as the disease spreads geographically, that becomes less and less feasible. And
Right.
listeners may know that there was a stage in which the FDA recommended that blood banks stop collecting blood in Zika areas and ship blood in there from other parts of the United States.
Right.
That all sounds nice, but it's awfully difficult to do that.
It is. Yes, absolutely true.
So I think we're very lucky that a test became available.
Mm-hmm. Well, and that there is a lot of truth to what you're saying, Jeff. That is very true. Let me before we get into the nuts and bolts of pathogen inactivation, and I promise everyone we will get there. I don't mean to postpone it, but there's one more thing that I wanted to get your take on, Jeff, if you don't mind, and that's you talked about all the drawbacks and the potential issues with the testing and the approach that we have now. One thing that I want to make sure that the audience is aware of is that there are things that we do test for where we still have some potential holes. And I'm speaking primarily about bacterial contamination of platelet products, though there are obviously other potential things with window periods and the like for other infections, but those are less of a big deal to me than the potential residual risk from a product that we are already testing, and that's platelet apheresis and whole blood derived platelets with bacterial contamination testing. Do you have any thoughts on that, Jeff, on the residual holes in that process?
Oh, I'm glad you mentioned it, Joe, and you're exactly right. There are holes there. The bacterial screening has been effective in that it has decreased the frequency of bacterial contaminated units and then transfusion transmitted infection, but it's not perfect. And as you know, some of these culture systems don't pick up all the infected units. Mm-hmm. So we still do have a small number of cases each year of transfusion-transmitted sepsis. There is an alternative approach to pathogen reduction for that, and that is point-of-release testing. I didn't necessarily think we were going to get into that today, but listeners should be aware that there is that alternative approach.
Right. Okay. And I don't. You're right. We probably won't get to that, but we'll hold it in reserve. Maybe we will. But we do need to move on, and we do need to talk about. So we've set the stage, and you've said that this is a new approach. This is a different approach. Well, it's not actually. I should rephrase. It's not really a new approach, but it is a different approach than our traditional approach. And so tell us what you mean when you say pathogen inactivation, Jeff. What specifically are you referring to?
Techniques to usually you add something to a unit of whole blood after it's been collected that will inactivate any remaining infectious agents. You can also add materials to either plasma or platelets to accomplish the same thing. And there are two main technologies that we could discuss. There are a couple of other technologies that are farther back. One of these technologies is developed by Cirrus Corporation in California. They use a sorolin compound. They refer to it as ametocillin. That compound, when added to blood, binds to nucleic acids. And when you expose that blood product to ultraviolet light, that bond becomes fixed between the two strands of DNA or between strands of RNA, and therefore the nucleic acid strands can't separate, and therefore they can't replicate. So now you've inactivated any DNA containing material in blood. And as we know, the only DNA material in blood that we worry about is viable lymphocytes. But it turns out that's a fringe benefit of the pathogen inactivation, because it prevents lymphocytes from multiplying, and therefore we don't need to worry about graft versus host disease, and therefore we don't need to irradiate those units, which is separate from the pathogen activation. The other technology, unless Joe, you want to talk about that a little bit more, we can.
Why don't you summarize the second one, and then we can talk a little bit about the differences between the two.
Okay, the other technology is developed by Terumo Corporation in Denver, Terumo BCT. That uses riboflavin, one of the B vitamins. And it's the same approach. The riboflavin is added to the blood product. Riboflavin binds to nucleic acids also. And partly it releases oxygen radicals which damage the nucleic acids. But also when that combination is exposed to ultraviolet light, there is more damage to nucleic acids. And so the same process has occurred. Essentially with both of these, you're damaging nucleic acids or binding them in a way that they can't replicate. Therefore, you've inactivated anything that contains nucleic acids in the blood product. Got it.
So, with these two main methods of pathogen inactivation, let's start from one very important point. Both of these are approved in many parts of the world, but what is the status of approval of these two technologies in the United States?
Yes. The Cirrus technology, which they call Intercept, is approved by the FDA in the United States for use for apheresis platelets and plasma.
Okay.
The Terumo technology, which they refer to as Mirasol, is approved in Europe but is not approved yet in the U.S.
Okay. So there are, I think it's fair to say there are some centers, some blood centers in the United States that are doing this. It's not an overwhelming flood of blood centers doing it yet, but there are some blood centers that are doing the Cirrus product. One other thing that I wanted to discuss about this, though, the distinction between the two. So you've got with the Intercept system, you have the sorolin compound, the ametocillin. With the Mirasol product, you have the riboflavin. Is there any difference, obviously, for both of them, to the products when and where they are approved, you add the substance, you use ultraviolet light to kind of cement the effect of the substance. Is there any difference in processing after that the light happens between the two systems?
Slight difference, Joe. With the Intercept system, there is they call a compound absorption device, little wafer that absorbs any remaining unaltered sorolin. So it's no longer free in the unit of blood. With the Mirasol system, there is not.
Okay.
Once you pull it out of the UV light box, I forget exactly, Joe. It may have to sit for a couple of hours, but it's pretty much ready to use.
Okay. And the thought behind that is just that riboflavin is a vitamin and is considered fairly inert, and there's at least some concern about the amotosalen having potential effects if it's directly transfused.
Yes. Yes.
Okay. All right. Fair enough.
Frankly, I don't remember offhand whether there's a lot of free riboflavin still left. I have a feeling not very much.
I see.
But in any case, as you say, it's a B vitamin, and so we don't have much. I should also say, though, with the Sorlin compound, I don't remember the details off the top of my head, but Sirius will say that it is similar to sorlins that are found in many foods, I think broccoli or asparagus, and that the levels are not particularly greatly different from the levels of those sorlin compounds that we have naturally in our bodies.
And that actually brings us go ahead, Jeff. I'm sorry. Forgive me, I interrupted you.
It is a time to mention, as people would expect, both of these companies have done extensive toxicity studies. They have looked at just about everything you could think of that might be a toxic problem, from mutagenicity to carcinogenicity, methods of excretion, that sort of thing. And the results of those studies have been quite acceptable. Okay. So that you can imagine what the FDA requires of Sirius to license their material, and the same thing has been done by Terumo. I may be jumping ahead a little bit here, Joe, but however, as these products come into more widespread use, which I assume they will, there will be issues that will come up, such as the neonatologists will wonder, can we give this to a 1 kilogram baby? And others will wonder about what if we give 50 units of blood to a trauma patient? Right. And so those are things that are going to have to be dealt with along the way. But it doesn't negate the fact that the toxicity studies have been very extensive and all have been satisfactory.
Excellent. You read my mind. That's exactly where I was headed, Jeff, to ask you about the toxicity studies. Okay. So with that background, why don't we talk just a little bit about the blood products on which these technologies can be applied? So we had mentioned bacterial testing for platelets earlier. So why don't we start with platelets, Jeff? How does pathogen inactivation apply to the use of platelets?
Okay, well, the Intercept system is approved in the United States, and as you mentioned, Joe, some blood centers are beginning to adopt this. One of the main issues in the development of this approach, apart from the potential toxicity, which has been pretty well put to rest, is whether these blood components are equally effective as current blood components. You get at that by clinical trials. So with platelets, a number of pretty well-structured clinical trials have been done comparing the effectiveness of Intercept platelets with ordinary apheresis platelets to prevent or control bleeding. I'm a little biased because I was involved in a couple of these. And at the time that we published what was known as the SPRINT study, that was the largest clinical trial of platelet transfusions ever done. There were around 600 patients, around 300 in each arm, controls versus Intercept platelets. The endpoint of that study was the proportion of patients who developed bleeding during the study, and we looked very closely at those patients. Our nurses spent about an hour to an hour and a half every day assessing bleeding in every patient on the study. So we knew exactly what was going on with those patients, and there was no difference in the likelihood of occurrence of bleeding or the kind of bleeding that occurred in those patients who got the Intercept plasma platelets versus standard platelets. A couple of similar studies were done in Europe, and so I think the clinical data is very strong that these Intercept platelets are equally effective to our current standard platelets in managing bleeding. Now, the next thing you're probably going to ask me is, what about platelet counts?
Yeah, you read my mind, Jeff. Absolutely.
All right. Well, not too surprising. The post-transfusion platelet counts following the Intercept platelets are slightly lower than with controls. When I say not too surprising, if one looks back at some work that Ed Snyder did with radio-labeled platelets in normal research subjects, he showed that the percent recovery and the length of survival was slightly lower in the intercept platelets compared to standard platelets. So this has to be factored in with the observation that these platelets are all equally effective in managing bleeding, but the counts don't go up quite as far. So this has raised the question of whether you need to end up giving more platelet transfusions in order to maintain the platelet counts. And I think Cirrus has a lot of information that they use to contend that this does not involve more platelet transfusions. They have data mostly from Europe and Switzerland and other places where they've totally converted to intercept platelets. One of the other things that probably helps this situation is, Joe, you've probably had other podcasts about this, but over the last several years, it's become increasingly apparent that you don't need to maintain platelets at the level that we were used to over the last 20 or 30 years. So the fact that the platelet count doesn't go up quite as much doesn't put patients at more risk of bleeding. And if you become more comfortable maintaining patients at lower platelet counts, such as 10,000, it may not necessarily involve giving more transfusions. I think the jury is still a little bit out on that, though.
Okay. Well, one thing coming from the perspective of someone who is medical director of a blood center, one of the things that I have heard many of my colleagues state as a concern, Jeff, and I'd love for you to address this with your perspective, is that as you know, with platelets, we often kind of live on a knife's edge of adequate supply versus crisis, and we flip back and forth seemingly by the moment sometimes. And I know that there has been concern expressed about decreased yields of platelets for when pathogen inactivation is used. And in other words, taking a product, just for the listeners, every platelet product, every apheresis platelet product by definition in the United States, well, at least 90% of them that you're testing has to have at least 3 times 10 to the 11th platelets in each bag. That's for apheresis platelets. If pathogen inactivation drops your yield, that may take you from a product that maybe you could split into 2 because it has over 6 times 10 to the 11th, down to maybe a single product. So, Jeff, I know you know where I'm going with this. There's been concern raised among my colleagues in the blood donor center industry about that issue and harming the yields. Do you have any perspective on that?
Only a little. I didn't, not in a blood center, so you are more informed about this than I am. But I didn't have the impression, Joe, that the problem was being unable to prepare doubles and having to convert to a single, so much as the problem was the difficulty in getting triples. That you might have trouble getting the number of platelets you need to make 3 products from each plateletpheresis. But it seems to me that our plateletpheresis procedures ought to be good enough that we could still make doubles. But maybe I'm wrong about that.
Well, and maybe I'm over. I was kind of using that more as an example, I should say. But you're right. I think the concern is more triples becoming doubles than doubles becoming singles. I will grant you that. I guess there among my colleagues, I do hear some concern about decreased yields for a variety of reasons, and that may be deeper than we need to go with this episode. But I will grant you that it's probably more of a triple to double issue rather than a double to single issue.
Well, and another aspect of this, we'll just be very brief because this could take us off on a tangent.
Okay.
A number of other parts of the world, as you know, do not use the same minimum platelet content as we do, the 3 times 10 to 11.
That is true.
Parts of Europe use, I think, 2.9 or 2.7. Canada currently uses 3, but I'm told that they are starting the process to try to convince Health Canada to let them go down to, I think, 2.75. So there's not harmonization of platelet content throughout the world.
Right.
And there's a fair amount of experience that these lower numbers work clinically very well in these other countries.
That is true, and in fact, there is good data in our literature from the so-called Plato study showing that giving lower doses works just fine, right?
Yes.
Yeah, absolutely. So,
Yep.
those of you that are listening, if you've never heard of the Plato study, I'll include a link to that on the website on the show page, just so it's a landmark study in transfusion medicine that you should be very, very well aware of.
The information that we were just discussing about platelet counts and bleeding things applies to the intercept platelets.
Okay.
I also want to mention, I said in the beginning, I don't have any financial involvement with any of this.
Mm-hmm.
Terumo's Mirasol platelets are approved in Europe, as are the intercept platelets.
Mm-hmm.
And so Terumo has also data, mostly from a French study, showing that the same thing, as I mentioned about intercept platelets. And that is, the bleeding is no different between Mirasol platelets and ordinary platelets. They also found the same thing, that the post-transfusion counts are a little bit lower. So although those platelets are not approved in the United States, they are approved in Europe with the same general observations about bleeding and platelet count.
Okay.
One last thing to say, that Terumo is quite far along in preparing to open their definitive phase 3 clinical trial in the United States, which of course they hope will lead to approval of Mirasol platelets in the U.S. But that's going to be 3 years or more off, because the trial hasn't even started yet, and it'll take a couple of years to do that trial.
Okay, Jeff. So thanks for filling us in on that. I do want to talk quickly before we leave platelets and get to other components that we can do pathogen inactivation with. And mention an article that you and some colleagues wrote in released in Transfusion, where you talked a little bit about costs. I think that in blood center world, we think about pathogen inactivation and we think about the increased cost that'll be associated with it. And I think hospitals do a little bit as well. But the point of your article was to discuss some of the cost savings that could come from pathogen inactivation. Would you care to comment on that?
Yes, and I'm glad to have the opportunity to make the point that while there will be additional costs related to the use of pathogen activation, there are a number of things that we can stop doing, and therefore we save some money. Number of the tests that we currently do are not mandated by the FDA. We do them because of FDA guidance, which can be adjusted. And so one thing that's not even in FDA guidance is CMV testing. One could stop CMV testing. I already mentioned earlier about the prevention of graft versus host disease by inactivation of lymphocytes. So one could no longer need to irradiate pathogen inactivated blood products. The bacterial culture systems that we've talked about could be eliminated. I'm trying to think of a number of others that you may remember the paper better than I do. One other thing gives me a chance to say is the duration of platelet storage. As you know, and as our listeners know, the reason it is now 5 days is because in the early days of 7-day storage of platelets, there were a number of cases of transfusion-transmitted sepsis, which caused the FDA to shorten the storage period to 5 days. Well, if we have pathogen inactivation, then we're not going to have transfusion-transmitted sepsis. So the dating period could be extended to 7 days. And one of the things that we did in that study is the study involved 4 major hospital centers: University of Minnesota, Stanford, UCLA, and Massachusetts General Hospital. And so we all looked at the amount of outdating that we now have with platelets at day 5 and made some projections about the number of units that could be salvaged, and it would be additional units to transfuse if we could extend the dating period to 7 days. It's a substantial number of units, and therefore that's a substantial value. If roughly an apheresis unit of platelets might be valued at about $500, that money adds up pretty quickly. So it's not something you stop doing, but it's new revenue, additional revenue that can be generated.
I
So
see.
there are a number of ways to look at this, and it's not necessarily going to come out to be cost neutral,
Hmm.
but the additional cost of pathogen inactivation is not totally just additional cost. There are some changes that we can make to help mitigate that.
I see. Well, and I'll be honest with you, Jeff. This is me speaking as an editorial comment. I hope that you're right. I am always concerned. You're right. Some of these things that we do are part of quote unquote FDA guidance, and every guidance, as you know, comes with a hey, you know what? This isn't law, but we all kind of know that even though it's not law, it's hard to get the FDA to walk back on something that they have put out often in a guidance. And the fact that we've been doing syphilis testing for as long as we've been doing this, again, this is my personal opinion, says that it's hard to get rid of stuff, I guess is my point.
You're exactly right. I agree with you.
All right. So go ahead, Jeff.
It'll be interesting to see.
It will. It really will.
As this whole process moves forward, I'm assuming there'll be more and more opportunity to get these issues on the table and begin these discussions with the FDA. We're never going to win on syphilis. Well, actually,
really? I'm sad now.
It does make allow one good distinction here too. Syphilis is a federal requirement. It's in the Federal Register.
That's true.
Almost all these other tests are not in the Federal Register, therefore they're not legally required.
I see. Things like West Nile and Chagas, for example.
Yes, yeah. Babesia also.
And sure. Okay. Well, so Jeff, we need to move on and talk a little bit about some of the other blood components that on which pathogen inactivation is used. So we've hit platelets. Let's talk about plasma. What's the applicability of this technology to plasma?
Yes, both of the Mirasol and the Intercept system can be used for pathogen inactivation of plasma. The Intercept system for plasma is approved in the United States. Both of these are approved in Western Europe, and it's equally effective in preventing or treating bleeding in patients undergoing acute blood loss, but also these plasmas have been used for plasma replacement in plasma exchange with TTP, and have been shown to be equally effective. And finally, some use in congenital coagulopathies, which are not single factor deficiencies. I got to admit, I don't know why I should hesitate to admit this. The best trial of frozen plasma has been in patients with acquired coagulopathy. These were mostly patients with liver disease. And this is a classic structured clinical trial. Half of the patients got ordinary FFP, half got Intercept FFP, and the outcome in terms of management of bleeding and use of blood products was the same. The studies that have been done in single factor deficiencies, there aren't very many of those patients around, and so it's not really a classic controlled trial. They compared things that were going on sort of before and after. And the same thing with TTP. There are so few of those patients that it's hard to get a lot of those patients together to do a randomized trial. So those studies compared different time points. They looked at what happened over the last 6 months to their patients, and then they started using Intercept plasma and looked at what happened to the following 6 months. And they were not able to see any obvious differences. So the data is what it is, and it's been used to support licensure. There's not quite as much data about Mirasol plasma, but those same sorts of data are out there, and they've been adequate for European approval. So I think in general, one can presume that these pathogen-reduced frozen plasma products are going to be as effective as existing frozen plasma products. They're not moving into use very quickly. Yes, they're not moving into use very quickly. I think because particularly the bacterial problem with platelets is one of the drivers to move the adoption of pathogen-activated platelets along a little faster than frozen plasma. I'm sure disease transmission occurs from frozen plasma, but it's not in the front of most people's minds, and so I think there's not as much pressure or feeling of urgency to, and then also, of course, there are other options. There is Octoplas, which is now available. So the adoption of Mirasol treated plasma is a little slower than platelets.
So let me ask you this, Jeff. You bring up you mentioned Octoplas, which is a solvent detergent treated plasma product, which is approved in the United States. Some of us that have been around blood banking for a while remember a previous experience with solvent detergent treated plasma in the United States that didn't maybe go quite as well. And we won't beat that to death, but there were issues apparently at the time with some reports of problems as a result of the fact that things like protein S and the anticoagulant factors were lower than expected in those products. The genesis of my question is, in any studies that have looked at the Intercept plasma and the Mirasol plasma, has there been any look at that to see whether those anticoagulation factors are lessened as we saw previously?
Yes, that has been explored, and those factors are slightly reduced, but they're not reduced to a level that people think is going to have a clinical risk or a clinical effect.
Got it. Okay. All right. So, Jeff, anything else on plasma before we move on to, I know, a topic that's near and dear to your heart, and that's red cells and whole blood?
Nothing. I think that covers plasma pretty well.
Okay, fair enough. Well, let us then, kind of the elephant in the room. We've talked about platelets and plasma. Obviously, the blood product that we transfuse more than any other is red blood cells. So what are the options that we either have available or have in the pipeline for red cells and or whole blood?
Yeah, Joe, I think the exciting thing is it's coming.
Yeah.
It's behind the platelets and plasma because it's been more complicated. With the Cirrus technology using the sorolins, that cannot be used on red cells or whole blood because the wavelength that is of ultraviolet light that is used for the sorolin amotosalen is absorbed by hemoglobin. And so they haven't been able to just take that and apply it to whole blood or packed cells. Instead, Cirrus has developed a totally different technology using a complex molecule that has an antibody that directs this molecule to DNA. But part of the molecule is a toxin. It's a distant cousin of an alkylating agent, which at first makes you nervous because, as you know, it's used to treat cancer.
Sure.
But this is a very distant cousin, and once again, extensive toxicity studies have provided reassurance that this is not going to be a toxic product in patients. But it's toxic enough that it damages nucleic acids. Ultraviolet light is not involved.
Okay.
So that technology was, fairly well along a number of years ago, and we were involved in one of two phase 3 clinical trials at the time. The clinical trial was carried out in patients undergoing cardiovascular surgery, and the good news was that there was no difference in the clinical effects of transfusion. There were no excess adverse reactions to the use of this. The name of the compound is S303. The use of the Cirrus S303 treated red cells. There was a separate parallel clinical trial going on in, I think it was either sickle cell disease or thalassemia patients, where they received multiple exposures. And in that trial, plus in a couple of patients in our trial, antibodies developed against the S303 treated red cells.
Oh, okay.
And so this led to a halt of the development of the S303 technology. We still publish the results of our study. They've been in transfusion some years ago. And Cirrus went back to the drawing boards, and they were able to determine that the combination of reagents they were using did not provide enough quenching to the surface of the red cell. So there was kind of neoantigen formation, which led to the appearance of these antibodies. Cirrus has modified that technology, has done extensive animal studies so that it still is the S303 molecule, but the specific methods have been modified so that the red cell surface does not appear to have any neoantigens.
I see.
A lot of in vitro work was done, and some phase 2 studies of red cell survivals in normal research subjects done. And that technology is in clinical trial now. A clinical trial in cardiovascular surgery patients has been completed in Germany. I don't know the results, but I've been told that they're just fine. A separate clinical trial of S303 is underway in Turkey in thalassemia patients. That, of course, is intended to look at multiple exposures to the red cells over a period of time. That's enrolling, and so I think it's about halfway along. So, those will provide great groundwork for Cirrus to apply in Europe for approval of this technology in Europe. They also have a clinical trial. I don't think has started enrolling in the U.S., but it's quite far along in design. I think they've selected sites, and I think that trial is also intended to be in either sickle cell or thalassemia patients. And so let me then turn to Mirasol, the riboflavin technology.
Right.
The Terumo guys lucked out in that the UV wavelength that they use for riboflavin can also be used with red cells. So their red cell technology is essentially the same as for platelets and plasma. You add the riboflavin, excuse me, exposed to UV light, and you get the effect. They've been able to do this both in packed cells and in whole blood. I'm sorry, I don't know off the top of my head, Joe, the status of the packed cell clinical trial, but the Mirasol whole blood work is sufficient that they are now approved for whole blood pathogen inactivation in Europe. I don't know if they've started to try to sell it yet, but they have a CE mark for whole blood in Europe. I know that Terumo is quite far along in planning a definitive phase 3 trial of packed cells in the U.S. So I'm sorry to be confusing here, but they can use this Mirasol method for either packed cells or whole blood.
I see.
They recognize in the U.S. there's almost no whole blood use. So the clinical trial that they will use to approach licensure in the U.S. will be packed cells. That's also, I'm pretty sure, going to be in thalassemia patients. The protocols are finished. I don't know whether they have final approval from the FDA, but I know they've identified trial sites, and they're pretty far along in working with those trial sites to open this phase 3 clinical trial of Mirasol packed cells.
That's fascinating.
I think you might know this, which may be one of the other reasons for your comment. I've been involved with the Swiss Red Cross in that we've been modifying, the Swiss have modified the Cirrus S303 method to use it on whole blood. And we're pretty close to initiating a clinical trial of S303 whole blood in Uganda. The reason to go there is if you want to try to show that you've prevented disease transmission, you're going to have to go where there's a lot of disease, and that's really not in the U.S.
Sure. Okay, so Jeff, all that is exciting. It's a new frontier out there for us. Obviously, there's lots coming down the pike and lots that's going to be happening. But I think it's important before we close this to make sure that everybody's aware of the data that's out there in terms of, well, I mean, we're doing this, so obviously it must work, right? I mean, it's important to at least briefly discuss, do we have information that this technology, using the platforms that you've described, that it actually works to decrease the infectious load of organisms, or to decrease the infectability, I guess is a better way to put it, of the organisms that could potentially contaminate blood products? So what information do we have on that, Jeff?
Well, Joe, that's the $1 million question. Right. Do these things actually prevent disease transmission? And there's very little data about that. There's a great deal of data in vitro in the laboratory, looking at the extent of killing of infectious agents in the lab.
Mm-hmm.
That gets into the number of viral particles or bacteria in volume of blood, number of, say, viral particles per mil of blood.
Mm-hmm.
And so there's a lot of data for both of these technologies showing how many viral particles per mil they will kill.
Mm-hmm.
There's a fair amount of variation in that. And there are some organisms for which the kill levels are different for the two different technologies.
Mm-hmm.
And in some cases, the kill levels are somewhat low, maybe only 10 to the 2 particles per mil or 100 particles per mil, which on the one hand might seem like a lot. On the other hand, both of these technologies, I think, will kill something like 10 to the 6th particles of HIV per milliliter of whole blood.
Mm-hmm.
That's a lot of viral particles. But one of the arguments that's also used is what kill levels are likely to be needed, because we're talking here about, Joe, apparently healthy individuals who walk into a blood center to donate blood, and they pass all of our criteria. And so it's pretty clear that somebody who's got 10 to the 6 HIV particles per mil of blood is going to be awfully sick. And what we want is technologies that will inactivate levels of infectious agents that are going to be present in relatively healthy appearing people. Some of that is known, but also the levels of infectious agents in apparently healthy people for a lot of these infections are not particularly very well known. So some of this has to be taken on faith. One of the other areas is envelope versus non-envelope viruses. Both of these technologies are not particularly effective against non-envelope viruses. Fortunately, that's not a huge problem, because there we're talking about hepatitis A or parvovirus, and those aren't much transfusion transmission risks.
Right.
Now, you were probably going to ask about a fantastic article in Lancet.
How did you know? I was. Yes.
This is spectacular because it is, to my way of thinking, the first clinical evidence that at least one of these technologies can actually prevent disease. This was a clinical trial done in Ghana about 2 years ago. It just appeared in the Lancet, I think about 6 months ago now. This was a clinical trial using Mirasol whole blood compared to ordinary whole blood in Ghana. And it was done in relatively stable patients. They were randomized. This was a classic randomized controlled clinical trial. Endpoint was prevention of transfusion-transmitted malaria. This is a really well-done study in which they also did DNA characterization of the malaria strains. So they were able to show whether malaria that occurred in patients following transfusion was the same strain as malaria that might have been in the donors. Short answer was, I think there were around 200 patients in the study, 100 patients in each arm. 100 patients got Mirasol whole blood, 100 patients got ordinary Ghana whole blood. And then of those 100 patients, you had to look at how many were exposed to malaria-positive blood, because there's no screening done for malaria in Ghana. And so there was no screening for malaria done in this study. And I'm going to be a little off on the exact numbers, but I think in the control arm, there were something like around 30 or 35 of the 100 patients who were exposed to malaria infectious blood, and 9 of those developed post-transfusion malaria. In the Mirasol arm, there were about, I think, 25 patients out of 100 who were exposed to malaria infectious blood, and only 1 of them developed post-transfusion malaria. So while there was 1 case of malaria from the Mirasol blood, this was highly different from the 9 cases from the standard blood. So it really established that the Mirasol whole blood was very, very, very less infectious for malaria. It wasn't 0, which would have been
Right.
9, but it was 1 versus 9.
Mm-hmm.
So, and that's the first real evidence of disease prevention.
That is exciting. You're right. There's not a lot of pure randomized control trial data out there like that. And and forgive me, Jeff, for it's just a slight correction, just because I just pulled the article up in front of me. It was 1 versus 8 actually.
Okay.
8 of 37 in the untreated group, 1 of 28 in the treated group. Okay. So.
Now, there is additional data, and I don't know this well enough off the top of my head, but for instance, some from Switzerland, which universally adopted intercept treatment of platelets, and they have a good hemovigilance system, and they have data about the number of patients with bacterial contaminated platelets during a year or two before and a year or two after implementation of intercept platelets. And they essentially found no cases of bacterial transmitted sepsis following the use of intercept platelets. So it's not exactly a contemporaneous randomized study, but there are some other good pieces of data around like that also are pretty effective in establishing that these procedures appear to decrease transmission of disease.
Very nice. Very nice. All right, Jeff. Well, before I let you go, there is one more thing that I want to ask you, and it's silly. I'll warn you up front. It's silly. So, here's the question. So, I've noticed that people are very particular about the terminology that they use, and I noticed that you are very specific with using pathogen inactivation, and whereas many articles that are out there say pathogen reduction. Is there any method to why you say inactivation rather than reduction? And you're not alone. I'm not suggesting that you are, but what's the deal? What's the difference between pathogen inactivation and pathogen reduction, if there is any difference?
Well, it's mostly semantic. I think several of us had it was a letter to the editor or something in Transfusion a while back suggesting that pathogen inactivation could be used to describe the overall process. Mm-hmm. And that pathogen reduction could be used to describe the particular blood product. By saying that this is pathogen reduced, you're not guaranteeing anybody that all the pathogens have been inactivated, because we don't. But, it doesn't make a lot of difference. I'm not going to lay awake at night about it.
Okay, fair enough. Well, Jeff, I think that we've covered a lot in our time together, and I absolutely know that my audience will really, really appreciate this. There's a lot of discussion out there about this, and as you know, the FDA has put out a couple of draft guidances about potentially involving pathogen inactivation techniques in prevention of bacterial contamination of platelets and the like. So I think once the FDA does their final version of that, whoever knows when that will be, we're probably going to be talking about this quite a bit more. So I really just want to thank you for spending the time with me and helping my audience understand this.
Well, I'm glad to do it, Joe. And also, if anyone who hears this finds any errors in what I said, please let me know.
You bet.
Okay.
All right, Jeff. Well, thank you so very much. I really appreciate your time. Have a great day.
You're welcome. You too.
Hey, it's Joe with just a couple of closing thoughts. Well, Dr. McCullough gave us a lot to think about in that episode, and I hope that was as useful for you as it was for me. Just as a nice solid overview of what's out there and what we're looking at and what we're doing with pathogen reduction / inactivation. The bottom line, for those of us in the U.S., it is coming. Well, realistically, it's already here. It just doesn't have quite the momentum that it has in the rest of the world, but it is coming, and there have been several things that are pushing that and will push that as we go forward, including things like an upcoming FDA guidance on bacterial contamination, which if it's anything like the draft versions, I think will push people in the direction of doing pathogen reduction. And just the recent implementation of Zika testing, which was a huge process that has the potential to be taken care of by pathogen inactivation. So Again, lots to think about. I welcome your questions and comments at bbguy.org, as well as on Facebook and Twitter. I hope that you'll sign up for updates at just weekly updates, no spam, at bbguy.org. And pathology residents, just a reminder, if you're looking for more information coming soon about a new project I'm working on for pathology resident review, just go to bbguybootcamp.com to sign up again for spam-free email updates. So that's it for today. As always, I hope that as you go through your day, that you'll smile and have fun, and above all, never, ever stop learning. Thanks very much, and we'll catch you next time on the podcast.